So today's chronic disease support session is on oral health. Maybe boring, but I think it has one of the longest histories of study of true root cause of diseases. I think it's really very, very interesting. And in fact, it was oral health and the study of it back in the late 1800s that really set the tone for what I think is a highly underappreciated causation of disease across a broad spectrum from acute to chronic today, and that is chronic infection. Okay, so chronic stealth infection. And so without further ado, I'm going to share the screen, and I will tell you that I shamelessly called one of our participants on Monday morning because I got one of the most interesting things you'll see, and it just sort of supports everything we're doing. When you talk about chronic disease, the insidious nature of it, the way it can catch up to you when you don't expect it, but it's been matriculating in the background for a long period of time, was revealed. Here's something really interesting to start off with. You know, our surveys are good and they're more robust than most, but this is a domino effect of poor health. But I just want to show you something. One of our participants, anonymous, filled out the chronic disease assessment. And this is an important take-home lesson. Brushes twice a day. Flosses daily. Minimal bleeding of the gums when flossing only. No big deal. Doesn't use Crest, so is trying to do something a little bit better, is using Tom's of Maine. Sees the dentist twice a year. Has root canals and crowns, and they've been in for a while. Claimed to have periodontal disease yet resolved. No mercury, had all those removed, never had a tooth extracted. So in her opinion, her oral hygiene's under control. But what I try to bring up last time, and I'll bring it up every time, is the continuum concept. That where are you on the oral health continuum? It's just like with a gut continuum. It's really hard to tell where you are. Optimal, ready to emerge with a problem, or in a state with a problem.
It was, and then it stopped.
So
I had it on the computer. Oh, okay, sorry.
What I got her to do is take an oral DNA test. And it turns out that Dr. Carter can do this as well. So here's her chart saying, okay, she has risks, root canals, but she thinks it's under. But she actually has, out of 11 or 12 pathogens they look at, she's high or moderate risk for 6 of them. So oral DNA revealed that even though she thinks she's in good shape, she actually has a pretty bad mouth. Most of it's probably under the gum line, in the roots, and she claims no pain. No oral pain whatsoever, no tenderness of the gums, nothing to speak of, because I had to go through a series of questions. So it's just an instructive thing. And, I've said this before, my friend Tom Lockensgard, we all have some degree of periodontal disease. We all have periodontal disease to some extent. So I'm not going to go through this exhaustively, but this is the recommendation from the dentist. And a lot of the things I agree with. I mean, look, every practitioner, they're in the business of making money, but they're in the business of health as well. Their job, if you read my blog from today, is to protect your oral health. My job is to protect your longevity and long-term health systemically. So even though we are working towards the same goals, there are some slight differences. So my general philosophy is that if there are teeth that can be revealed that have some infection in them, pull them. That's my number one thing, but that's not, like I said in my blog, that's not necessarily just the easy thing to do because, you've got to stabilize the tooth. Depending on where it is, they can start shifting. what's the integrity of the mouth, the bones. It can get complicated. So pulling a tooth isn't always the right thing to do. But from a long-term perspective, though, if you don't pull it, you've got to be very fastidious with the several things recommended here, maybe on a regular basis. And yeah, I know, Linda, it's a little hard to see, but it'll be up, or I can post it on the blog site tomorrow, so that's what I'll do. And also on the blog site today, I posted a technique I found that seems to be fairly well out there, that may be an improvement over general root canal surgery, but you still have the root. And Amy was kind enough to comment and do some research and says that, you know, ultimately what they do after they clean the root is they put some adhesive and things like that in, and that can ultimately separate. So it's not a permanent thing. You've got to be vigilant of these root canals, maybe every other year, have them checked. So now I have this here because the lady with this pathology has glaucoma. And she's had a long history of root canals, more than 10 years. And she had definitive periodontal disease diagnosed at some point in her life. So she's had this slow, insidious, inflammation draining from the nerves in her teeth into her central nervous system. And guess what? The retina is all nervous tissue right there, very close to where that bacteria is leaving the oral cavity. So, you know, we got to think in terms of the continuum. And last time when we talked about the genesis of health, I said, look upon the gut as a lifelong pursuit. Guess what? Look upon the oral cavity as a lifelong pursuit. And I'm going to try to accelerate a little bit and just run through some of the associations between periodontal disease and systemic disease. But I want to get to the solutions part on what I do and what I recommend. I don't publish all my recommendations that I do. Okay. I'll just express them verbally. But that's just the way it is. So, but here's the long history. This was rewritten around 2008 by Robert Gibbons, who looked at the history of Frank, what's his name? Frank Billings. It's written right there. And Charles Mayo are really the founders of this concept. Billings preceded Charles Mayo, the founder of the Mayo Clinic, by about 20, 30 years. But Charles Mayo presented, you know, in major talks around the country that dental hygiene and dental procedures will be a very big, important part of medicine from a systemic perspective in the future. And this was 1916. This was over 100 years ago, and we still kind of have crickets. You know, we're still just working on preserving the mouth and not thinking about the systemic relationship. So that's Frank Billings, Charles Mayo. I've been made happy by discovering that I've only added to the observation of other physicians in pointing out the connection between the extraction of decayed and diseased teeth and the cure of general diseases. And he was humble enough to say he wasn't the first to discover it, Benjamin Rush, 1809. So the concept is really focal infection. It's not the flu or strep or meningitis or some other broad-based infectious disease. These are infections that can inhabit specific compartments of tissue in our body and create insult, but the horse can leave the barn as well. Okay, and we'll talk about that. So just some of the statistics, and oftentimes in the literature I find that they have cause and effect backwards. Even in good medical journals, they have cause and effect backwards because they just don't understand chronic infection. They just don't. Even periodontal disease, it's so straightforward. But So research indicates gum disease may increase the risk of heart disease and stroke. That's reasonable. That's a root cause. It's the gum disease. It's the bacteria that's inflaming the tissue. And look, if your gum is bleeding, that vessel is weakened. And when it bleeds, you've induced a hemorrhagic stroke in very small tissue. Hemorrhagic is breaking, okay? Whereas ischemic is blocking. So when you do that, that's a mini hemorrhagic stroke. A stroke is really in the brain, but you get the concept. We think of it, it's a hemorrhagic event in a vessel. And the one we think about the most is a stroke. So, oops. So really, bleeding gums, tooth decay, loose teeth, tooth pain, bright red gums, bad breath. But really, any level of bleeding gums is a sign, because this is like the iceberg. The gums is just the tip of the iceberg. What's going on underneath, we don't know well. Surmise if you're having bleeding here, even under pressure from floss, that what's going on underneath can take down a steamer. It's more insidious. So I mentioned the concept of a biofilm, I think, last time. But these organisms live in two main domains. They live in biofilms. So dental tartar is the biofilm. It's the housing project for the organisms. The organisms aren't just floating around in our saliva, they're hidden. But when they get into the systemic environment, they can hide inside cells, but they can also be taken up in biofilms. One of my colleagues, Herb Allen, he's the head of the dermatology medical school at Drexel. He just wrote a paper on COVID and how it forms biofilms as well to protect itself from immunity. So what we see and what I test for is when we have this periodontal infection, we see systemic inflammation. And the challenge we have is that in traditional medicine, they hardly even do a CRP, C-reactive protein. That's the inflammation in your vessel, the sign of which is telling you how vulnerable that vessel is to hemorrhaging, okay? Fibrinogen is a repair factor. If it's up, it means you have more repair and recovery. Very seldom is that fibrinogen test done in the standard of care. Amyloid A, dyslipidemia, which really means cholesterol. And actually, two really fine researchers out at the University of San Francisco showed that when you have chronic infection like this or systemic infection, that your lipids will go up. Your LDL will go up and your total cholesterol will go up. And the reason why total cholesterol goes up is, number one, free cholesterol goes up because your liver is synthesizing it, because cholesterol is one of the most important repair and recovery molecules of any molecule we have in our body. And LDL, we'll talk about this ad nauseum, so we're all more fluent on cholesterol than our doctors, because our doctor can never end around us because we're going to know more than them. But LDL is simply a soap, a detergent molecule that carries cholesterol and other fat-soluble molecules through a water-based bloodstream. Tell me if this is the first time you've heard this from me.
Yes, it is.
It is, okay. Good, okay, well. It's important because it's such a simple concept. And it's so misunderstood that low density and high density lipoprotein are just carrying agents for fats. They're just a surfactant. They're just a soap. You know, when you wash your dish with no water, with no detergent, and it's greasy, it stays greasy. That's because oil and water don't mix. So you put the soap in, that makes it miscible. That's exactly what LDL does with cholesterol in your body. All it is.
99% of viruses and bacteria. Once dry,
So I'm managing to cruise ahead here somehow, but it's the plaques. Let me be very graphic. The plaque inside a vessel, right in here, I know it's hard to see, and we'll talk about this in the cardiovascular thing, is no different than a blackhead on a teenager, a pimple. It is a pus sac of inflammatory cytokines that have gathered together as an immune response to control infection. And then they glom it up, macrophages and all that. And that's what that whole white pus sac is. It's all just a sac of cytokines. That's what a plaque is in a heart attack, stroke, Alzheimer's, whatever. So these arterial plaques are created by the immune response to the infection. And it's well documented in periodontal disease, but we don't extend that out to other organisms, but it's true. So diabetics are 2 to 4 times more susceptible to gum disease due to elevated glucose levels. That's partly true, but it's also the other way around. The gum disease causes diabetes by creating inflammation at the cellular membrane level, which actually imparts insulin resistance to cells. So there is excess glucose, but that's secondary to the inflammation on the cells that cause the glucose to collect outside. And it's an insidious process. Why would the infection cause that? Because they want glucose. Microorganisms tend to be more metabolically active than our own tissue. And so they have high energy demands, glucose of which is one of them. That's why diabetics have more vascular diseases. They have more, they get in this vicious cycle of becoming more diabetic over time. There's more cancer, which is very often has an infectious etiology, which means causation, root cause, things of that nature. We think of dental pathogens as just being things that live in the gums or the bone, the jaw, because really when you lose your teeth, it's the jaw that broke down, so it's breaking down bone tissue. That's why periodontal disease can lead to joint pain. It can lead to you shrinking over time as you age because it gets into your spinal fluid and causes the bony tissue of your discs to start collapsing. That's why you shrink when you age. Okay? But there are other organisms that are common, at least from my perspective, that are not necessarily the normal suite, excuse me, of periodontal organisms that were tested in the oral DNA test. There are other organisms. And one of them, my favorite enemy, Chlamydophila pneumoniae, is really the cause of pneumonia, emphysema, COPD. So a smoker doesn't die from smoking if they get lung cancer or COPD or whatever. The smoking causes an opportunity for Chlamydophila pneumoniae, mycoplasma, TB, other lung-related diseases to take hold. So that's why non-smokers can die of the same disease as a smoker. It's really susceptibility to the organism, and smoking just increases that susceptibility because your body's spending time repairing inflammatory damage rather than fighting these opportunistic organisms.
Sure.
So this is really interesting, that when you have something in your stomach like H-Pylori, it had to come from someplace. And H-Pylori, Nobel Prize in Medicine 2005, Warren and Marshall, 2 Australian pathologists that showed, and they had to demonstrate on their cells because no one believed them, that H. pylori was the cause of stomach ulcers, not stress. you know, stress can play a role. I mean, stress ties up immune bandwidth, then makes H. pylori maybe more prolific, but ultimately it's the H. pylori infection. But we probably just don't swallow H. pylori in some food or some other source. It probably matriculates in the gum, and that's what this study suggests. You know, the kitchen. So in my house, we have a kitchen upstairs where I am, and then we have this walkout basement with a galley kitchen, and that galley kitchen is mine. And I can assure you that kitchen is the dirtiest place in the house, not the bathroom. You know, because you have fuel, you have food, you have water, you have surface area, you have all the right environments for things to be dirty. The mouth is the exact same way. You know, we have immunity, we have saliva that has some immune function, but a lot of things can fester in the mouth, and H. pylori is one. So if you have stomach distress and things of that nature, it may have emanated from poor oral hygiene, or let's just say unfortunate oral hygiene. I mean, my mother, I don't know what was her story, but she had really bad oral hygiene for 50 years. Root canals and everything. And she lived well to the age of 93. And I won't get too personal with this story, but I know someone very close to me that had some fluid buildup, young person, and took a diuretic and felt groggy and weird for like 3 days. So my mother, because she had a stenosis caused by the periodontal disease, was on diuretics. And so I always thought the periodontal disease was causing her to be a little loopy. And now I realize 10 years later that it was the diuretic medicine that she was on for blood pressure and for water shedding, because she had a stenosis in a heart valve that was causing fluid to back up. So they were constantly, she didn't want to have surgery, so they were constantly shedding the water. But that drug actually was making her loopy. It wasn't the periodontal disease in the brain. That's just a sidebar. It's a realization I had very recently. You know, I thought I was taking good care of my mother, but I guess I was, but we didn't have a lot of choices. You know, I mean, the fluid was backing up her lungs. We had to remove it, and she refused surgery. So what do you do?
Yeah.
But so this is important. It's not a huge risk, but the devil's in the detail. It's all about the little things. So periodontal disease has been isolated as a contributor to different types of cancers. Cancer, it's just an inflammatory process, a constant inflammatory process. So 14% higher risk of, what's that little guy there, of developing breast cancer, 59% greater risk. This is a relative number, so it's not like one for one, but look, pancreatic cancer, 80% of people are dead in a year. So this is a really important risk factor, and this came out of Harvard and Brown. So, and then breaking news, Dr. Loudon always supplies me the good stuff. This came out August 12th, that gum disease is tied to colon cancer risk. And really what they're showing is there's a significant statistical increase in polyps, and polyps have a statistical relationship to malignancy in the colon. So it wasn't a direct outcome of colon cancer, but sort of what they call in medicine a surrogate endpoint. But there's no question about the risk. And you know, what are they looking at, though? They say periodontal disease, but were they looking for H. pylori? You know, if you have periodontal disease, you may have comorbid H. pylori, which then is clearly a risk factor for colon cancer, stomach cancer, things of that nature. So it's all the quality of the workup, how broadly we test. If we're just testing for a narrow range of periodontal pathogens, then we may say, hey, this is being caused by the periodontal pathogens, where what I find is so very often when we have something like this, when it's able to fester in your body, then other things that are around in the environment or already nascent in your body can proliferate and develop as well. That's why I always test people for mycoplasma and chlamydophila pneumoniae, because they're so common. And if they're elevated, I'm not saying, okay, that's your cause. I'm often saying, you have vulnerabilities, which means that other organisms can probably be participating in a disease process as well. And then we always want to know, how do we treat? You know, do we need to go through extraordinary testing methods to find those other organisms? Or is there sort of a generalized treatment program we can use? And I defer to the latter usually. It's not always successful, and then you have to do more testing. But where are we? Where are we? There's no question about this connection. Treponema pilatum is very common. It's not syphilis, but it's related to syphilis. So back before Alzheimer's, 120 years ago, they called it general paresis, which was really neurosyphilis. And that was the first cases of dementias that were well documented. Then Alzheimer's diagnosed this very strange version in this lady named something Dieter, German, and the autopsy showed the plaques and the tangles. But fast forward to 1993, and really a good friend of mine and colleague in Switzerland, Judith McCloskey, has shown unequivocally that Alzheimer's is at least exacerbated, if not caused, by spirochetal infections. And spirochetal is a fancy name for a spiral-shaped pathogen, usually a bacterium. And many of the periodontal bacteria are spiral in shape. So she wrote in 1993, Alzheimer's is spiroketosis with a question mark, and she spent the last 25 years proving it 6 ways to Sunday. And, you know, I'm convinced. And so we always are looking for the infection. And, you know, at the end of the day, the spirochete is not affecting the nerves so much. Some viruses affect nerves. I touched on this a little bit last week. But it's really affecting the microvasculature. Just like in periodontal disease, you have bleeding gums. It's affecting blood flow in that. And so Alzheimer's is really just a diffuse disconnection of little mini blood vessels we call capillaries. And they have inflammation in them. They have infection. What I've read very recently, I read a paper, you know, we're always trying to learn and understand why it takes so long to reverse people with Alzheimer's if they are really compliant. It's one of the hardest things to reverse, not because it's so hard, but because of the time domain. And I found out in a paper I read, and it was really above my head, I'll have to tell you. And so I've only read it once, but I'm going to have to read it a few more times. But basically, it showed how microglial, the brain's immune system, when it gets activated, is very difficult to deactivate. That's why when I work with someone like Marvin Berman at the Quiet Mind Foundation, they use techniques to try to calm the brain, Quiet Mind Foundation. But you got to remove the inflammation first. So I think, you know, we've developed a better mousetrap in doing the combination of these things. But it's far from perfected, for sure. I'm going to unmute folks. I don't hear anything right now, but I think Linda, I think I still have you muted, but this is an interesting study that I watched Grand Rounds, and Grand Rounds is supposed to be doctors from all ilk, and Johns Hopkins developed this. The patient didn't go to specialist to specialist to specialist to specialist. All the specialists collected around the patient, particularly in hospital, right? But this Grand Rounds, I was listening to the University of Arizona, they were all neurologists. I'm saying, that's not Grand Rounds. But anyway, they showed very clearly that periodontal bacteria can get into the placenta and highly correlated to premature birth. So if you have kids or grandkids or child rearing age, make sure their teeth are in good shape, because, you know, we want our babies to get off on the right foot. And if they're premature, they haven't fully developed, there's something going on when you have a premature birth. The brain actually sees them as a quasi unviable, you know, individual at that point, because the heart's beating, so they're individual. But
Dr. Lewis, may I ask a question?
Oh, please, please. Thanks. You saved myself, Linda. Thank you.
No. When you're talking about periodontal disease, do you also include root canals in that general? Is it a general heading, or is it specifically periodontal?
Well, you know, I use it as a general heading for what I really mean, and that's a really great question. If I've never differentiated, I'm just looking at infection in the oral cavity, anywhere in the oral cavity, in the bone, in the gums, in the roots. So, you know, I generically have been calling that periodontal disease because it's something that people understand. But, you know, I think if you have an infected root canal, that's periodontal disease.
Okay.
You know?
So all of these can be relevant for someone who has root canals.
Absolutely.
Okay.
Absolutely. And I think the root canals are a hiding place. They were there, and hopefully this group is beginning to understand better that these organisms don't just come and go. I mean, they actually do come and go, but they hide. They can hide in biofilms, but they can hide in the cavitations that are created when you have an implant or a root canal, and they can hide in the dead tooth's network of channels, you know, and there's really no immunity there. You know, really you need to have blood vessels within a certain distance of tissue for the immunity to have an effect. And it's generally what's called 3-cell diameters. You have to have a capillary, and that capillary is gone. That tooth no longer has blood flow. So it's a place where things can hide out to some degree. I mean, they need fuel too, but they're opportunistic. They're the Taliban.
But you know, it's a very difficult situation when you have root canals, because if the only thing to do is to have your teeth pulled, it's also miserable not having teeth.
Yes.
I mean, it makes, I know because I'm missing 3 of them. I went down this route of having my root canals pulled, and I stopped because I'm so uncomfortable with the 3 that are missing that I didn't want to go 3 more. And
Linda, that's why I said at the very beginning, it's not always as straightforward as I make it out. And I think you're completely in my camp. You want to pull them, but there's other things to be considered there. That's why, you know, I'll send out that sheet that this doctor recommended to the lady in our program that got this treasure trove of things. But I think what you have to do is you can't be passive about it. You probably have to do some evaluation every once in a while for pockets, maybe some ozone treatment, some other types of treatment to keep on top of it. I mean, look, everywhere in our body is hiding places for pathogens. Nobody listening to me has a 0 white blood cell count. That means, you know, your immune system is always out there on patrol, fighting against infection day in and day out, okay? If we were pathogen free, our white blood cell count would be 0, and it would just pop up when it needed to be. So we all have it. And, you know, this is just one place where we need to pay, I think, more particular attention than other places. But the gut, same thing. I mean, H-Pylori disturbing your stomach acid is more insidious than periodontal disease, in my opinion. You know, because of all the downstream autoimmune conditions that can stem from a leaky gut. So it's not like the worst situation. We just want to be aware of it and always be considering options. But I think you can't be passive about it. And so there may be some other things you need to do. And, you know, you need to find a dentist that doesn't just think as a root canal as, yeah, you're all set. You got a root canal now. You're all set.
Yeah.
We cleaned the bacteria out. We got most of it. No big deal. You know, you want to have someone that has a little more long-term consideration of the consequences of that. That's all. And they're out there. Yeah.
Thank you.
You came in unclear. Do you want to say it again, Linda? I didn't quite hear you.
Oh, I just said thank you.
Oh, I heard you the first time, but I wanted to hear it twice.
Good. It's a good one.
I'm not an expert on the process here, but all I can tell you is that these organisms, the bone is a very diverse organ. We don't appreciate how complex it is. It's structural. It's a mineral reserve. It's where you produce white blood cells. You know, it's a very complex set of tissue. And the bacteria that live in your mouth are feeding off the bone of your jaw. And pretty much they're just as happy with bone anywhere in your body. You know, but in the root, I don't know, it must be more susceptible or vulnerable or easy to get to. I'm not sure, but there's no question that periodontal disease in the mouth can then, if uncontrolled, can have the effect of chronic pain, loss of bone mass, all those types of things. So maybe a little audacious here. Here's how to prevent and reverse periodontal disease and its nasty complications. So what I want to talk about here are things you can do to at least do a better job managing superficial periodontal disease. Definitely what I'm talking about is not going to get into the root canals or into the depths, you know, but at least if we can, the 80-20 rule, if we can get rid of some of the garbage, we'll be in better shape. So it's a biofilm. The periodontal disease or the gum disease lives, or the organisms, before they are classified as causing disease, shall we say, are on the gum line, and that's the tartar buildup. That's the biofilm. Biofilm is a fat-soluble substance. And so in chemistry, we learned at the very beginning, like dissolves like. So fat dissolves fat. Water and fat, another word for fat is oil, are not miscible. So they really don't, you know, go together well, and they don't dissolve each other. So everything we're doing with our over-the-counter dental hygiene products are doing very little to curb. Basically, what we have since 1958, when Crest came out with fluoride, is we have a fluoride delivery system. And fluoride does nothing against periodontal disease. So nothing over the counter is doing anything for periodontal disease for the most part.
Can you hear me?
Yes.
Oh, good. And there's no noise. When I first was seeing a Lyme specialist, he put me on numerous antibiotics, oral and injected, and I developed a black film on my teeth. And then I found tea tree oil toothpaste, and it got rid of that black film. And I'm wondering, does that mean it also is an antidote for biofilm?
So most of the essential oils will have some ability to break down these films. And tea tree oil is one of the best. And tea tree oil is very antibiotic. I'll tell you a little story if you want to endure me for a little bit longer. But I mean, the basic thing is anything that's fat soluble will have a better effect on it. But just like, you know, my desktop is laminated, that's a very hard plastic. I can pour solvents on it and it really doesn't break down. Same with these biofilms. They're polymers. They're cross-linked polymers, and they're hard to break down. So we have to, you know, whatever we're doing daily now, you want to adopt augmented methods, you know, you can keep doing what you're doing. I don't want to steer you away from what your dentist is telling you to do, but you want to augment it with daily activities that will reduce biofilm buildup. And so the easiest thing to do that's very popular, trying to find what slide I'm on. So standard oral care products fail because, you know, the best thing you have is a brush. At least that does something, but the toothpaste does little. Oil pulling. So you take, if anybody's not aware of oil pulling, just go on YouTube and put in like oil pulling and Josh Axe. And if you don't want to find it, I can send you a video on it. I think it's useful to see a video. But you're literally putting coconut oil, and now they have liquid coconut oil, so it doesn't have to melt first. MCT oil. And you swish it around for a while. The longer you swish it around, the more likely you are to start breaking down that biofilm structure. So if you just put it in and spit it out, then you probably haven't done much. Remember, everything's the Gaussian curve, right? This asymptotic curve. So you got to go a while before you really start breaking it down. And so what I do with oil pulling, Louise, to your point, is I will put carefully an essential oil in the oil I use to do the oil pulling. Wintergreen, cinnamon, tea tree. Tea tree oil is a pretty potent oil in terms of its flavor, but I actually have come to like it, and I will put my toothbrush in tea tree oil to, number one, clean it, and number two, then I'll kind of like tap out the tea tree oil and brush my teeth with straight tea tree oil once in a while. It's a very strong biofilm breaking antibiotic agent. One time I put too much cinnamon oil in, and I was in pain. Anybody put essential cinnamon oil in their mouth? Amy, ever do that?
No, but the gum, even cinnamon gum, can burn your mouth.
Wow.
Hi, Pumpkin.
The brand I found,
What's
my
happening?
teeth would get black inside of 2 weeks. It was awful. The brand I found by accident was called Desert Essence, and the tea tree oil.
Louise, put on the chat, if you can find that, just write the name of it on the chat, and then I can share it. That'll be shared with the group, and I'll share it at some other point. But yeah, I just get some essential oils, and the cinnamon oil is really amazingly harsh. It makes habanero seem like nothing. So it was my mom when she was 91, and I wanted to pull the rest of her teeth, but one of her favorite activities in life was to eat corn. And so we couldn't pull the corn on her, Linda, because she wanted to anchor those dentures. So here I am with a rotary toothbrush, and I morphed from this pose to having a face shield on. Because Jasmine, my wife, she was in medical, so she brought me home a face shield. But we would go at those 6 teeth, floss them, coconut oil with a little cinnamon, brush them well. I think peroxide, people asked me last time about peroxide. I think that's okay, but at the end of the day, we're trying to the most important thing is to break down the film, not to kill the bacteria. Because the bacteria that's out, your saliva is kind of handling. It's the stuff that's hiding. That's what we're trying to get. So that's why the oil pulling is the best thing to do. But I do other things other than just oil pulling. And being a scatterbrained scientist, I don't do anything particularly regularly, but except for my saltwater rinsing. So I have a large jug next to my sink of water, and it has a good amount of solids at the bottom. And what I do is I simply sip off the top, and that is what's called a saturated solution of salt water. And I'll swish around. I'll floss with the salt in there to try to get the salt into the crevices. I'll brush with the salt in there. And the last thing I'll do once a week or so is I'll take some of that salt water and put it into a water flosser and go right along the gum line to try to use the force to go underneath the gums a little bit. And that's exactly what a periodontist does, you know, to scale underneath the gums of any biofilm down there. And salt, even though it's not a fat, has the strength to break down the biofilm as well. So this is sort of what I do: a tablespoon of quality salt, 1 cup of warm water, but that goes into my water flosser. Okay. But otherwise, I just have a big jug full of salt at the bottom, and the top is the 90% is just clear, but it's as salty as it can ever get. So it's totally concentrated. They call it a saturated solution. So I do that rather than, and you know what salt? You know your teeth are bone. They're made of, you know, minerals, and so salt is minerals too. So this actually supports building up of enamel. You know, enamel is a dynamic thing too. Otherwise, we'd all have, you know, we'd be really long in the tooth as we age, right? But you know, you can remineralize teeth, and that's what fluoride is. Fluoride is just a very, very aggressive mineral that will penetrate into, you know, the enamel. But essentially, any mineral that's indigenous to that structure will go in. So that's why I use the salt water. This came out in 2002. It's an 88-page book. Anybody who wants it's hard to find. I know the publisher well, Jeremy Abbott in New York City. I've met him several times, and you know, it's really not being sold anymore, so I'm happy to share the PDF with anybody. It's 88 pages. It's Scientific American, so it's quasi-technical, but their graphics are beyond, you know, beyond any other kind of publication. They really put a lot of effort into the quality of their graphics. So this, which will be posted, is a link to an old brand of mine. It's an 8-minute video on oral health. So if anybody's interested, they can see it when they watch the video, and I can see interest. So what I'll do is I will just send this out if I haven't. I think I already did actually, but I'll send it out to our group so that you can have and watch this video. It's not a long one, but covers the basic same topics. But so what I do, just to give you the whole, I don't want to confuse you, but I think the best thing to do is, this is what I do. I don't brush my teeth in the morning anymore because I don't really have breakfast. So there's nothing really building up. And I was too aggressive brushing when I was younger. So I just oil pull, swish around, maybe floss, 10, 15 minutes in the shower, anything like that.
Yes.
Then in the evening, I'm mainly doing salt, brushing, flossing, water picking probably twice a week. And then every once in a while, I'll use something more aggressive, like a little iodine on my toothbrush, povidone. You know, don't swallow it. And then sometimes I go 3.0, and I use the thing that made Louise's teeth black, minocycline, which is a antibiotic, but there's no better biofilm buster than that, particularly for periodontal disease. And everybody in Asia uses it in the dental office.
What is it called?
Minocycline. It's an antibiotic.
How do you use it? You're ingesting it, or?
No, what I do is I do it once a quarter, 4 treatments. I take 2 capsules, and if you're really interested, I can show you where to buy it, where you can go online and tell the doctor you have this and that, and they'll write you a script. It'll cost you $150, but you'll have a supply that'll last you for dental purposes for 10 years. Okay? But I take the capsule. I usually have a little shot glass, a small container, and I open up the capsule, and now I have 2 halves. And I put 1 half right on my dried toothbrush over my little shot glass so I don't lose any. And then I just brush for 10 minutes. I get a little frothy, and it's yellow and all kinds of stuff, and it's kind of, acrid tasting. Not really disgusting, but it's a little tart, if you will. And I just brush for 10 minutes. Tongue, gum line, whatever, floss, spit it out, done. And I do that. So I have 4, with 2 capsules, I have 4 treatments. And I'll do that in the morning, and the evening would be 2, and then the next morning and the next evening would be 4.
Do you time it for 10 minutes? You time it?
Or an engineer might time it like you, but not me.
Well, I mean, 10 minutes is a long time.
I'm trying to keep that in my mouth. When you think about treating yourself with an antibiotic systemically, it's in there for 12 hours. So I'm trying to keep it in there concentrated for as long as I can.
Okay.
So each quarter you do this 4 times using 2 capsules.
Correct.
And you do that like over a short period of time, like 2 days.
2 days, that's it.
2
And
days.
when I'm done, when you go to the dentist and the hygienist has scraped all the tartar on the back of your teeth and you can feel the ridges?
Yeah.
And then like right now, if you haven't been to the dentist for a while, you use your tongue, you can't feel the ridges. When you do this treatment, you can feel the ridges again.
Okay.
I'm going to get that.
I'm serious. I'm crestfallen because I'm somewhere I have an old bottle of minocycline and I can't find it. I have doctors that'll prescribe it for me, but I don't want to hassle them. They've got to keep track of who got it and why and the CPT codes and all that nonsense. So I just get my own.
And you trust where you get it from?
I did an 18-month treatment on myself with antibiotics from India and Canadian pharmacy. They call themselves Canadian pharmacy, but they're Indians. And look, I went to MIT, and we had the Chinese, the Japanese, the Indians. The Indians were superb chemists, like
really
super fastidious.
Tony. Hi, buddy.
For real.
I got my mother some tetracycline from India once because she couldn't get it here.
Yeah.
That was a while ago. So, and I wasn't sure. I mean, it worked for her. So,
the India has more middle class than Americans have people. 350 million middle classers in India, and they're pretty sophisticated. I mean, they have the caste structure sort of, but let me tell you, they're bright people. They're bright and entrepreneurial.
yeah.
So yeah, I just make sure when I talk to them, I say, I think I have a source that I trust. It's India, not China.
Yes.
I spent 8 months in India.
Say again?
I spent 8 months in India.
Did you, Marie? How'd you find it?
Yeah, at the time it was in 2020. About 20 years ago. The emission control was bad, but the people were fantastic.
Yeah.
People, and when you walk down the street, they always eye contact. I mean, they keep moving, no threats, just the eye contact is always there.
Yeah. Yeah, no, I found the researchers were, really, of course, a lot of them weren't staying in the country, so they were just here on a, temporary research grant or something. And so they were really they were on task. They were getting it done. So I had a lot of respect for them. So
Yes, I do too.
anyway, any questions about oral health? Once again, just like the gut.
I have one.
Go ahead, Linda.
So am I correctly hearing you say that you believe to some extent your oral health can be managed without removing root canals?
Yeah, I think so. Yeah. Mm-hmm. Mm-hmm.
Okay.
Because
it's been a dilemma of mine for years what to do about my root canals.
I think it's option 2. It's not like you only have one option. It's not the best option, but you have to actively be checking. Cone beam is an X-ray, see if there's cavitations, treat in there. Look, my brother, he's 10 years older than me, and he's never going to listen to me ever. But he's with the VA. He was in the military. He was a West Point guy, but he has pus in his roots, and you can survive, but you got the best way to take care of it, Linda, is make sure everything else, to the extent that you can, is taken care of too, because your body ultimately is what's taking care of it. So if you have root canals, then you just need to bring your entire game up across every strata of health.
Makes
gut and hormone, thyroid, and just immunity. Just make sure everything's in check to the extent you can. Then you can probably, because ultimately when they cause problems is when they get out of the barn. But the biggest problem as we age is they get out of the barn into the brain. And so, but just prophylactically doing, biocidin and things like that, just to try to just to support immunity. So these are herbal, antibiotic, biofilm busters.
Honey. Hi, baby.
So all these different things you want to do to take extra care, Dr. Carter, my functional doc, I'll have him on one of these times. He's doing ozone treatment at home and all. Nobody wants to spend what he's spending on supplements and treatments.
Yeah.
But he's had glaucoma for 30 years, so he has something systemic. Just like an oral infection, he has a retinal infection that he may or may not have solved. The glaucoma is going to be there because of the way he treated it with surgery and all these other things, or laser over the time. It's basically burned the retina. He didn't have the pleasure of having Dr. Tremp as his doctor, Louise. But so in some respects, he has a focal infection for life that he has to keep on top of. I had a focal infection in my heart, causing AFib. So I have to pay particular attention. I worry about, overstressing it. Or just getting sick.
Yeah.
Because I don't think it's gone. I think it's just under control.
Mm.
Yeah.
Thank you. This is very good.
One quick question. Xylitol, which they are putting in toothpaste and chewing gum, saying that it does help to bust biofilms in your mouth. Do you agree with that?
I'm not sure.
And is it chemical? Is it chemical or is it natural? Do you know that?
The xylitol and erythritol, I'm not an expert in those sugars, so it's they're decent, what do they call it, sugar alcohols. They seem decent from an insulin response perspective, but I'm having a hard time believing that something with so many OH groups on it is non-polar enough to affect biofilms. Now, the one that has some interesting, so that's just a guess though, Amy, but the interesting thing is stevia seems to have some interesting published data showing that it has the same kind of antibiotic behavior as some of the herbals.
Wow.
I grow stevia. It's amazing.
Yeah, is that
nice?
So I could brush my teeth with it?
have,
I'll do it and report back.
didn't hear it here, but possibly. You gotta do the oral DNA test before and after. That's the only way we know for sure.
Yeah.
Otherwise, it's all anecdotal. But with minocycline, it's anecdotal. But let me tell you, there's a 50, 60, as long as minocycline's been around, 40, 50 years, there's a very good understanding of its fat-loving lipophilicity, and its ability to have an impact on periodontal disease. And most Asian cultures aggressively use minocycline to treat periodontal disease. And they do it in America too, but to a much lesser extent. And, it's been around a long time, and I consider it, particularly for the gut, one of the least active antibiotics for the gut.
How do you spell that?
It'd be MINOCIN is the generic, and I think the other name for it is MINOCYCLINE.
Now, at one point, my family doctor, my allopathic and holistic physician, Glenn Rothfeld, had asked me to ask Dr. Tremp what antibiotic he recommended for the Q fever and the Lyme. And Dr. Tremp said minocycline, because it's fat soluble and it's the friendliest to your brain.
Yeah, it has some neuroprotectant properties. I don't completely understand it yet, but I probably understood it at one time, but I'll have to go back and read that. But basically, it's quelling inflammation. So the tetracyclines, I know the world #1 researcher in tetracycline, and I'm having a conference call about a project I'm working on with him, but he worked with a Nobel Prize winner on these things. And tetracyclines, he's designed tetracyclines. Minocycline is one, but new ones that have no antibiotic properties, but they're strictly anti-inflammatory.
Wow.
And then, you can change the water solubility, the fat solubility, blood-brain barrier penetration. He has molecules that I believe are superior for Alzheimer's than minocycline, and I'm trying to raise money to work with him on those. But, see, antibiotics are not a very, shall we say, well thought of category of pharmaceutical, but they're actually probably the best. They're the only ones that really truly treat disease. Yeah, there are consequences to it, and microbial resistance and all that stuff. And so, like, what Dr. Tremp used to recommend would be minocycline and clarithromycin. And there's actually because a lot of the organisms are these pneumonia type things, and clarithromycin is really good at treating chlamydia, pneumonia, mycoplasma, things like that. But I wouldn't get clarithromycin. I would go to Canadian pharmacy and get roxithromycin, which isn't available in this country. It was manufactured by the same company in France, but when they brought the molecule to the United States, they were both relatively new. And it was kind of like, which one do I do, VHS or Beta? Those of you old enough to remember that.
Yeah, no.
We picked VHS, which was inferior to Beta. And the French did the exact same thing when they promoted clarithromycin into the United States and spent the $1 billion getting it approved. Roxithromycin, if you look at the studies in Europe, outperforms clarithromycin in many different facets. QT interval is something they worry about how it affects the heart. These so-called macrolides, not so-called macrolides, affect the time between the first and second blip in the heart, and that can be problematic with people with heart failure. But it's also requires lower dose, less toxicity, more anti-inflammatory properties. So I took minocycline and roxithromycin for 18 months. Never missed a dose, full dose. Because I had Lyme disease, and Lyme disease it can be a mess. And I just wasn't gonna worry about the intravenous. I mean, I know I had it in the chronic phase, so I just said, look, I'm going to treat this one time and hopefully get rid of it.
Yeah.
And I
Smart move.
I never tested myself before or after, Amy.
No?
Never had a test.
But you feel good.
But I just knew, I mean, you know, you got to know what you have. It might have been a chlamydophila pneumonia. I don't know. But my doctors back then, before I met Dr. Trump, had no clue. So it's like, my best friend's a cardiologist. I said, look, came up with one line on the Western blot. He said, oh, you don't have it then. I said, well, then why do I have AFib? Oh, we don't know. It's like, he's my best friend. Craig Brett runs up at the Mercy Hospital up in Portland, Maine, you know?
Tunnel vision, you know?
Tunnel vision.
Yeah.
All righty, folks.
Okay. Thank you so much.
So much.
Thank you.
Thank you, Tom.
No idea what we're going to talk about next week, but it'll be something.
Yeah, and I got to book a session with you and talk about all these things and more.
Pretty soon, you guys are going to be at my same level, I hope.
Yeah, right.
You're going to laugh. From the great courses, I got the organic chemistry DVD. I'm very ambitious in being able to have a better understanding.
Look, when I was at Worcester Polytech, they called me the organic kid. So I had Morrison and Boyd, which was that thick. And then I got this other one from this British guy, Advanced Organic Chemistry, just because I wanted to read that book too, to beat Arthur Patton. He was only going out of one book, and I had the two books that I was going from.
That's competitive.
Kids. It's a long story. It's a long story, but it was a fun one.